Hello, learners. Today, I welcome you to Module 3, where we shift from sociological foundations to public health policies and programs in reproductive and child health. The first lecture links theory with practice by discussing India's demographic transition, fertility patterns, and the evolution of national health programs for reproductive child health. The aim is to understand how population dynamics influence policy and why specific interventions were developed at different stages. By the end, you will see how India's demographic trends shaped the design of RCH programs and where challenges still remain. Demographic transition theory explains how populations evolve over time with modernization. It describes 4 to 5 stages beginning with high birth and death rates and moving towards low birth and death rates as societies industrialize and modernize. India provides a fascinating case study because its states are at different stages of this transition simultaneously. Some states resemble early stages with high fertility, while others show advanced characteristics with low fertility and mortality. Understanding demographic transition is essential to link population dynamics with health programs and policies. Stage 1 is often described as pre transitional, agrarian phase in which epidemics, famines, and frequent shocks kept life expectancy very low. Fertility remains high because early marriage, limited contraception, and strong economic incentives for child labor and elderly support make large families a rational household strategy. Mortality is driven by infections, poor nutrition, unsafe water, and the absence of organized public health system. So, even high numbers of births translate into only modest population increases. Maternal mortality is substantial, and the age structure is very young, with large share of deaths occurring in infancy and early childhood. Seasonal scarcity and subsistence farming amplify vulnerability, producing what demographers call Malthusian checks that hold population growth in check. In the Indian context, scattered smallpox campaigns or local sanitation efforts existed, but without mass vaccinations, antibiotics, or obstetric care, their impact was limited. Understanding this baseline clarifies why the earliest gains in the transition came from simple public health measures like safe water, immunization, oral rehydration solution, and clean delivery practices that sharply reduced mortality before fertility begins to fall. It also sets up the logic for stage 2. Once death rates decline rapidly with basic health advances, continued high fertility produces a surge in population growth until social and economic changes later alter reproductive behavior. Stage 2 is characterized by the swift mortality decline driven by clean water, sanitation, vector control, antibiotic, and organized immunization measures where fertility stays high because marriage patterns, desired family size, and limited contraception change more slowly. The immediate result in a widening gap between births and deaths, producing a youth heavy age structure and a sharp rise in the dependency ratio that strains schools, food systems, and housing. In India, malaria control, smallpox eradication, oral rehydration therapy, and expanded primary health care were pivotal, reducing infant and child deaths even in rural districts. As survival improves, parents initially retain high fertility norms for security, labor needs, and sun preference. So, population momentum accelerates despite falling mortality. Rapid urbanization and migration intensify during this phase, creating new demands for jobs and urban services and exposing the policy need for coordinated health, education, and employment planning. The perceived pressure on resources and services provides the political impetus for national family planning programs. Social marketing of condoms and pills, and later spacing methods alongside sterilization. Over time, as child survival becomes predictable, schooling expands, and women's work and aspirations rise. The preconditions are set for stage 3, where fertility finally begins to decline and the demographic transition advances. In stage 3, that is late transition, fertility declines while mortality remains low. As households recalibrate desired family size in response to rising child survival and the increasing costs of rearing and educating the children. Key drivers include girls' schooling, later age at marriage, women's labor force participation, urbanization, and wider access to a diversified contraceptive method mix beyond sterilization to spacing methods. Public programs, they shift from a narrow target orientation to client centered counseling, emphasizing informed choice, quality of care, and postpartum family planning. In India, progress was heterogeneous. Southern and western states moved rapidly with early investments in female literacy and primary health care, while parts of north central belt advanced more slowly due to entrenched social norms and service deficits. Fertility differentials by education, wealth, and caste community narrowed over time, but did not disappear, underscoring the need for equity focused strategies. The age structure becomes youth heavy but stabilizing, opening a window for a demographic dividend if employment, skills, and investments keep pace. With mortality already low, the policy agenda pivots to quality maternal newborn care, adolescent health, and spacing contraception to avoid high risk births. This stage sets the condition for stage 4, when fertility approaches replacement level and population growth moderates towards stability. Stage 4, advanced transition, it denotes low fertility and low mortality, yielding slow or near zero population growth and narrowing base in the age pyramid. In Indian contexts like Kerala and Tamil Nadu, sustained investments in female education, primary healthcare, and social protection pushed the total fertility rate below replacement while keeping life expectancy high. The benefits include fewer preventable deaths, healthier childhoods, and the fiscal space to focus on quality of care rather than only on coverage. Yet, new challenges emerge as population starts aging. Rising old age dependency and growing demand for chronic disease management, long term care, and palliative services. Labor markets may face shrinking cohorts of young workers, prompting policies that raise female labor force participation, improving productivity, or attack retain migrants from high fertility states. Social policy must adapt, strengthening pensions, geriatric cares, and community support systems while safeguarding reproductive choice and preventing coercive pronatalism. Finally, India's mosaic transition means national planning must reconcile divergent realities, coordinating transfers, migration management, and health financing so high fertility regions and aging states advance together without widening inequalities. India's fertility patterns have changed significantly in recent decades. The total fertility rate has declined nationally, but wide regional disparities remain. Southern and western states have achieved replacement level fertility, while states in the north and the east, such as Bihar and Uttar Pradesh, still have high fertility. Urban areas typically see lower fertility compared to rural areas due to better education, access to contraception, and higher costs of living. Socioeconomic status and cultural preferences, including son preference, also strongly influence fertility behavior. Fertility decline in India has been driven by multiple factors. Women's education is the strongest determinant, as literate women marry later, use contraception, and prioritize fewer children. Urbanization changes the economics of childbearing, making large families less viable. Access to family planning services provides practical options for limiting family size. Policy interventions from the early family planning program to the RCH initiative have also accelerated fertility decline. These factors interact, creating uneven progress across regions and communities. Despite this overall progress, challenges remain. States like Bihar, Uttar Pradesh, and Madhya Pradesh continue to have high fertility rates due to entrenched cultural norms, poverty, and low female literacy. Early marriage and early childbearing contribute to sustained high fertility, limiting women's education and employment opportunities. The unmet need for contraception, especially among young and rural women, remains high. Gender inequality continues to reinforce these patterns. A woman often lacks autonomy in reproductive decisions. Addressing these challenges requires targeted interventions. India's demographic pressure led to the launch of the world's first national family planning program in 1952. Initially focused on controlling population growth, the program evolved over time to address broader reproductive and child health issues. The link between fertility and development became central. A high fertility was recognized as both a cause and a consequence of poverty. Understanding demographic transition thus helps explain why India invested so heavily in population policies and RCH programs. The National Family Planning Program of 1952 marked a historic moment. Initially, it was framed narrowly as a population control initiative. In the 1970s, the program became notorious for coercive sterilization drives, which created distrust and resistance. Over time, criticism led to a shift from demographic targets to a broader reproductive health approach. This evolution reflects the need to balance national concerns about population growth with respect for individual rights. The transition from pressure to choice was a major milestone. The Reproductive and Child Health Program, launched in 1997, represented a paradigm shift. It moved away from fragmented vertical programs towards an integrated client centered approach. RCH Phase 1 focused on safe motherhood, child survival, and reproductive tract infections, sexually transmitted diseases prevention. Importantly, it emphasized decentralized planning, allowing local needs to guide interventions. This approach recognized that reproductive and child health could not be addressed in isolation, but required comprehensive, integrated services. RCH Phase 2 built on the earlier framework but emphasized quality of care and equity in service delivery. It introduced landmark initiatives such as Janani Suraksha Yojana, which provided financial incentives for institutional deliveries and the integrated management of neonatal and childhood illnesses strategy. Adolescent health programs also expanded, reflecting recognition of the demographic dividend. Phase 2 marked a significant step towards improving maternal and child survival outcomes while reducing disparities. The National Health Mission, launched in 2013, integrated the National Rural Health Mission and the National Urban Health Mission. This created a unified framework for health services across rural and urban areas. Reproductive and child health remained a central component, but now with a stronger health systems approach. National Health Mission emphasized equity, community participation, and accountability. This integration reflects India's efforts to modernize healthcare delivery while sustaining focus on maternal, child, and reproductive health. Several landmark programs were rolled out under RCH and NHM, National Health Mission. The Janani Suraksha Yojana incentivized institutional deliveries to reduce maternal mortality. Janani Shishu Suraksha Yojana made maternal and child health services free, including drugs, diagnostics, and transport. The RMNCH Plus A approach integrated reproductive, maternal, newborn, child, and adolescent health into a continuum of care. ASHA workers, that is, accredited social health activists, community based health activists, became the backbone of service delivery, bridging communities and health systems. Together, these initiatives represent a holistic strategy for improving reproductive and child health. The RMNCH plus A approach, introduced in 2013, was a major innovation. It emphasized a continuum of care, ensuring that interventions span across all life stages, from reproductive health to adolescent care to safe motherhood, newborn care, and child survival. The A for adolescents highlighted India's demographic dividend and the need to invest in young health. The approach also emphasized convergence across programs, integration of services, and accountability through measurable outcomes. This life cycle, this life cycle perspective has been key to sustaining health gains and reducing fragmentation. ASHA workers, introduced under NRHM, revolutionized community health in India. They act as a vital link between households and the health system. Their responsibilities include counseling women on pregnancy, supporting institutional deliveries, mobilizing for immunization, and educating communities about nutrition and sanitation. Importantly, Ashas are women selected from their own communities, which enhance trust and acceptance. Beyond service delivery, this symbolizes women's empowerment, serving as health activists and role models in villages. RCH programs have contributed significantly to India's health gains. Maternal mortality has declined from over 400 deaths per 1 lakh live births to below 100 in many states today. Infant mortality has also decreased to below Infant mortality has also decreased thanks to better immunization and neonatal care. Institutional deliveries have risen sharply due to programs like JSY and JSSK, that is Janani Suraksha Yojana and Janani Shishu Suraksha Yojana. Contraceptive prevalence has expanded through with regional disparities. Their achievements show the power of sustained programmatic investment even in a resource constrained setting. Despite progress, serious gaps remain. Regional disparities are stark, with high mortality rates persisting in poorer states like Bihar, UP, and Madhya Pradesh. Fertility decline has stalled in certain regions, reflecting unmet need for family planning and cultural barriers. Quality of care remains uneven, with issues of overburdened facilities, inadequate staff, and insufficient follow up. Equity remains the biggest challenge, with marginalized communities often left behind. These gaps underline the need for context specific, equity focused strategies. India's reproductive and child health programs are now firmly embedded within the Sustainable Development Goals. SDG 3 explicitly targets reduction in maternal and child mortality, aligning perfectly with RCH objectives. SDG 5 on gender equality reinforces the importance of empowering women in reproductive health decisions. Other SDGs such as education, poverty reduction, and sanitation are also closely linked. This integration reflects the global recognition that health cannot be achieved in isolation but depends on cross sectoral investments and coordinated actions. Policy evaluation in India reflects a gradual shift from population control to reproductive rights and choice. Early programs prioritized demographic targets, but this led to coercion and public backlash. Over time, the focus moved towards a right based, client oriented approach that values informed choice. Decentralized planning under RCH allowed districts and villages to adapt interventions to their specific needs. This policy shift has helped improve community trust and entered sustainability of programs. Monitoring and evaluation have been critical to India's RCH programs. Indicators like maternal mortality ratio, infant mortality ratio, and total fertility rate are regularly tracked to assess progress. Surveys such as National Family Health Survey, district level house survey, and sample registration system provide the essential data. These tools help policymakers identify gaps, track disparities, and evaluate program effectiveness. Data driven decision making has strengthened accountability and allowed for evidence based policy shifts. When compared internationally, India shows both strengths and challenges. Its fertility decline has been significant, but some Asian peers like Bangladesh and Sri Lanka achieved faster reductions with fewer resources. These countries invested heavily in female literacy, community based services, and accessible contraception. India's challenge has been its massive scale and diversity, with states differing widely in cultural practices and resources. International comparisons remind us that while India has made progress, it must adapt the global lessons to its unique context. Looking ahead, India's RCH strategy must prioritize equity, ensuring services reach the poorest and the most marginalized. Quality of care must be improved, not just covered. Adolescent and youth programs need expansion given their demographic importance. Digital health technologies such as telemedicine, mobile apps, and electronic health records often are promising innovations. Future policies must balance traditional service delivery with modern solutions, ensuring inclusivity and sustainability in achieving health for all. In conclusion, India's demographic transition has profoundly shaped its public health policies and programs. From the world's first family planning program to the integrated RCH and National Health Mission framework, policies have evolved in response to changing needs. While major achievements have been made in reducing mortality and fertility, gaps remain, especially in poorer states and marginalized groups. The future requires a continued focus on equity, respect for rights, and adoption of innovative solutions. Module 3 will build further on these foundations to explore policies in greater details. Thank you for now.